Okay, good afternoon, everybody, and welcome to the Herts Valley's AGM. I think it's really pertinent just to explain to people that for the second year running, we've had to do this as a virtual event. And the statutory part of the AGM was actually held a few months ago. So this is very much us updating everybody in the CCG and obviously all of our population and practices about what we've been doing. So the first thing to say is that over the last 12 months, we've been continuing to develop the Hertfordshire and West Essex integrated care system, very much spearheaded by our accountable officer, Dr. Jane Halpin. And we're joined today by Beverly Flowers, our Director of Integration and Systems Transformation for our ICS, and she will say a few words shortly. Now, as we're shifting from the CCG to the ICS taking over our responsibilities in April of next year, we are spending some of our time actually ensuring that all of the governance arrangements are in place. And as I said, we held that statutory meeting of all three CCGs on the 8th of July. If you weren't able to see it at the time, it is recorded and we'll be putting a link out on the chat later. So today is about reporting and I hope celebrating what we've been doing over the last 12 months. And David Evans, our Managing Director of the CCG, as well as our guest presenters, will do that in a moment. Just important to mention that we will be the chat function, which is that button at the top there. We will be able to collate the questions in the chat and very much hope that we'll have some decent time to actually be able to answer some of your questions. Immediately after today's AGM, we're going to be joined by Ayunkansola Oja Aromakudu, who is going to be looking at the effect of health inequalities. So I don't want to prejudge that, but it's an incredibly important part of our work at the moment, addressing those health inequalities and making sure that we get the best for all our populations. So I'd just like to share a few personal reflections of my own in terms of what we've been doing over the last year. I mean, we all know that we live in unprecedented times. And the first thing I just want to quickly say is that, you know, the loss of people in our own system, our patients, our population, has been truly shocking. And we know that has had a major impact on everybody, as has the level of need, of health and care need through the pandemic. But I'd also like to say that although despite those awful parts of the pandemic, it has also shown the best of our system, the best of colleagues working together. And I think that we still absolutely want to maintain the care and the safety of our patients in everything that we do. So we've got many reasons to be proud of the work that we've done, and a lot of that has also been about spreading the spread of the virus and then treating those who've unfortunately contracted it. And we want to ensure that people can continue to access us. So our GP services, our hospitals, our community and mental health service colleagues have continued to transform the way that care is provided for our population. And vital health services have been maintained throughout the pandemic, and you'll hear some of that today. We are determined as a CCG and as an integrated care system to build on the best of the innovations that we've learnt over the last year and the new ways of working. And we're going to talk a little bit about that later on. So I would like to use this sort of final opportunity, if you like, in our last AGM to just mention some of the key workers who have really supported us throughout this. And I hope that if I miss anybody out, people will forgive me. First of all, we've had our pharmacists supporting the delivery of medicines to shielded patients. We've had volunteers. My goodness, we've had fantastic volunteers who have marshalled patients at vaccination clinics, manned phone lines and helped vulnerable people. Our care home workers have been extraordinary and have had to deal with incredibly hard times, and we absolutely salute them. I want to mention a little bit about the vaccination programme, which has been so important in the fight against coronavirus, not least my colleagues in primary care and general practice, and especially our primary care networks and federations who have actually organised a lot of the programme throughout. We've also worked really closely, as I've said, with our voluntary sector colleagues. Without them, both the ones that were organised by general practice and the ones that were organised throughout the health and care system, those vaccination clinics would not have happened. And I think we recently reached the milestone of having delivered 2 million vaccinations across Hertfordshire and West Essex, which is absolutely outstanding. So finally, I want to say a big thank you to our hardworking and dedicated CCG colleagues. Absolutely, our GP membership have been at the forefront of this, but there is an enormous team working behind the scenes who have also been working, and without them, we wouldn't have been able to deliver. The system wouldn't have been able to have delivered the care and the vaccination programs that we have done. So I think the pandemic has really shone a light on how we can, what we can achieve for patients when health and care services come together. And that increasingly integrated way of working will be developing over the following year. So I think this is a timely moment to ask Beverly Flowers to talk a little bit about that. So thank you, Beverly.
Thank you, Nicholas. I really just want to echo Nicholas's comments. It's been a very challenging year for the NHS and for the wider population, and COVID's had a really big impact on all of our lives and how we all work. I think it's important and it's really good to take a bit of time out to reflect on the achievements of the CCG and the achievements of the organisations across the NHS and the work that they've done during the past 12 months against the background of the pandemic. I'd also, on behalf of the kind of wider ICS and the wider system, want to express my thanks to all of the staff, both those that have been very visible during the pandemic and those that have worked in the background to keep services and to keep things happening and care still being delivered to a wide range of people across our patch. Within that, I also include all the volunteers that have worked for us within the system and really helped out in the past year. We're now moving forward into a world where CCGs will become the integrated care system, and we will continue to build on a number of the things that people from within the CCG are going to talk to you about in the coming hour or so. I think for the population of West Hertfordshire, there is a very good basis on which to move forward to continue to deliver really good services to the local population, both across primary care, community settings, and in partnership with both social care and the local acute hospital sector. That was all I wanted to say, really, and I hope you enjoy the rest of this session, and I'm going to hand over to David Evans.
Thank you, Beverly. Hi, everybody. My name's David Evans, and I'm Managing Director for Herts Valley CCG, and I'll be talking you through, alongside a host of colleagues, a review of the year and some of the great work that the CCG staff and clinical leadership has delivered over that period of time. We know that COVID has taken over a large amount of our headspace and our day-to-day lives, but actually alongside that has been some significant transformation. Primary care roles, we've continued to strengthen our primary care workforce, expanding the range of clinical roles in GP surgeries and primary care networks. Primary care networks describe the groups of GP surgeries in the local area, and we have 17 in West Hertfordshire. Having these networks now means that physiotherapists, pharmacists and paramedics are working alongside doctors, nurses and healthcare assistants, making it easier for patients to see a health professional with the right skills quickly. And this will be a significant advancement in terms of how we've developed primary care going into the future. As you can see, a growth in our social prescriber roles within those primary care networks has grown in a huge way, so that we now have 24 posts in West Hertfordshire, and that means that we can link more patients into services to help social care issues and address some problems, particularly around some of their root causes of why their ill health is occurring. And that could be around social issues such as housing or loneliness, or other areas of need that is not based on health, but a combined health and social care problem. With support of the social prescribers, GPs, nurses and other health professionals, we're able to refer patients to a set of non-medical services that can help them emotionally and practically. Each of our primary care networks employs a social prescriber who supports patients and carers by doing things like putting them in touch with local support organisations within the voluntary sector, organising doorstep deliveries and welfare checks for vulnerable and elderly patients and their carers. Their work in the past year has been fundamental in helping those most vulnerable in our community, and during the lockdown, reaching out to them through lists held by primary care and others of potentially vulnerable people. We've been able to ensure that they've had food parcels and they've had drops and support in terms of medicines as well. But they're not our only social prescribers, as back in 2014, we worked with Hertfordshire County Council to develop a small community navigator service. In a similar role to the link workers, a team of 20 community navigators now provide help both in the community and in the hospital, access through the Hearts Help Advice line and website. So most of the link workers and community navigators work together in localities in integrated teams with a senior navigator to manage them. Just to give you a sense of what's been achieved during the pandemic, Hearts Help dealt with 140,000 calls between April 2020 and March 2021 across Hertfordshire. And the Hospital and Community Navigator Service dealt with more than 6,000 cases in West Hertfordshire, and doesn't factor the people who are supported by the link workers employed directly by PCNs, so that number's even higher. Most of those 6,000 people went on to get help from our amazing voluntary sector groups and communities, which have really pulled together during the pandemic. And as a result, we can now show that they're improved in their mental well-being. We have people who are less lonely and use their GP services less, and use the right service to support them. At an integrated care system level, we're also developing a no wrong door approach, building on hugely successful partnerships, which will have enhanced during our COVID response to make sure that everyone can access support. Link workers are key in additional health inequalities. They'll be addressing those, and they help you think about what matters to you, not what matters with you. And most of the time we're focused on what is the matter with you, and we're moving that shift for some of our most vulnerable citizens, and this can be life-changing, and we've got some really good examples of that. I'd like to also talk about the great work that our estates team have been doing around new and improved GP premises, and that's a key activity for the CCG and something that's really important for patients and staff alike. We've continued to make good progress, as you can see from the slide, and with the last 12 months following the merger of Berkhamsted Practice Group with Rothschild and Premises Project in vacating a wing at Gossham's End, completed in January 21. So lots of work have taken place in that space, and that's just one example. We've also been working on new purpose-built premises for village and Latimer surgeries in London Colney, and the CCG has also approved schemes to support the relocation to new or improved surgery premises. So significant work taking place in that space, and lots of innovation happening. So without further ado, I will now hand over to some few of our GPs who will provide some updates. And the first one is from Anna Benson, who will be talking about mental health.
Hello. So the focus has continued to be on delivering the NHS long-term plan for mental health, and great work has been going on despite COVID-19. there is predicted to be the biggest negative impact from the pandemic in the areas of anxiety and depression, children and young people, eating disorders and crisis. No real surprises. And these are actually areas already in focus with the NHS long-term plan. In addition, the plan work has continued on delivering a core 24 service in acute hospitals, expanding the specialist perinatal service, expanding the IAPT programme, transforming community mental health services in a meaningful way, and developing Wave 2 individual placement support for employment. To manage these changes, new services have been introduced, for example, 111 Option 2 for mental health. Working with both NHS and voluntary sector partners has ensured the mobilisation of service provision, and that includes the online offer, as well as the single point of access, Contact Us web interface, and obviously an explosion of quality self-help and guidance online. There has been a real shift in promoting early intervention and self-help and mental health awareness amongst all public agency, including schools, social care and hospitals. Specific and vulnerable and underrepresented groups are being proactively targeted with offers of appropriate mental health help. Primary care community pilots have been adapting to the new ways of working, and their service supports those with moderate mental ill health, but not unwell enough to require a secondary care level of psychiatric treatment. They're working remotely and face-to-face. The ICS has this year successfully won a bid to NHS England and Improvement to enhance adult community mental health services over the next 3 years. So they're building on the work already done to provide a full range of appropriate mental health services. To do this, there's been quite a lot of collaborative communication across all stakeholders, and that continues and actually is probably stronger than ever. The introduction of virtual meetings has enabled better attendance and more frequent meets, thus speeding up the delivery change. Aims to improve the physical health inequalities suffered by those with severe mental illness by working with physical health care providers, including GPs and hospital departments. Schemes to effectively offer treatment for those with a dual diagnosis are running, including a community alcohol detox programme in Watford, and groups working on ways to integrate mental health properly into the physical healthcare framework management pathways, the ECFs, are underway. So that was a whistle-stop tour of mental health over the last year for the CCG. Dr. Vicky McCulloch can't be here today, but she's asked me to update the AGM regarding learning difficulties. So she says, in order to reduce the risk of increased unnecessary deaths in people with a learning disability, annual health checks have remained a priority throughout the pandemic, and work is starting on a pilot to assess the value of a learning disability care coordinator to help the PCNs deliver high numbers of high quality, focused annual health checks. The collaborative approach to the COVID-19 vaccine for all people with a learning disability and their carers was a huge success, as it was with SMI. And we are all grateful for everybody for their hard work and the reasonable adjustments which were made. And she finishes by saying access to cancer screening for patients with a learning disability is one of our priorities, and the community learning disability nurses have a 10-month pilot project to help the surgeries and HVCCG improve the cervical screening uptake in their learning disability patients. So that's learning disability and mental health in a nutshell. Please don't hesitate to contact myself or Dr. McCulloch if you have any other questions.
Okay, I will now update on children, young people and maternity services within Herts Valley CCG. And there should be a slide that can accompany the presentation. So continued work has developed on a programme of work and transformation around Herts and West Essex vision. And the vision is that we will ensure all children in Hertfordshire and West Essex have the best start in life, irrespective of where they were born and live. We will deliver improved health and wellbeing outcomes for all children and young people, and will ensure that the voice of the child is at the heart of all we do. So significant work based on that vision, which will be around tackling health inequalities, promoting ill health, improving multidisciplinary working and integrated care pathways, and improving outcomes for children and young people with long-term conditions, and delivering, importantly, personalised care closer to home, with a strong emphasis on the whole family approach. Now, we have some paediatric transformation priorities that the team has all been working on, and those include the Pediatric Advice and Guidance Hotline. The teams have been working significantly hard on this, Ivani and Rami and Mel and team within the CCG, and it was launched March 2021. The next phase will be linking it to Consultant Connect pilot rollouts, and that's with a whole multidisciplinary partnership across our health and care partnership of West Herts Hospital Trust, Primary Care, within the ICS as well, Herts and West Essex senior clinical teams. We also have the Healthier Together website. We felt advice for parents, young people and pregnant women, as well as clinical resources to support healthcare professionals, wasn't necessarily easily accessible, and we needed to promote that more so that people could understand and be able to manage the advice that they needed to prevent them from escalating into healthcare services unnecessarily. And then that's linked to educational programs that will be set up in this year. We have an integrated asthma and wheeze pathway, and that's again nurse-led service, and it aims to increase diagnosis of asthma and wheeze, facilitating appropriate management and preventing exacerbations. And again, this is focused on ensuring that the children and young people get their support in the right place at the right time. Can we go on to the next slide, please? So, projects that are in development, as well as the transformation taking place, are referral assessment services to coordinate specialist referrals and the care onwards. We know that there's ways in which we can improve and be faster and slicker at that. The neonatal jaundice pathway, which has been co-designed with community services. And one key one that's coming along at the moment is around the obesity, to review the end-to-end obesity pathways for children and young people, as we know this is a considerable challenge across our country nationally, but also something that we need to support locally with a targeted approach. The newer developmental pathways are still pathways that we are transforming, and we agreed a program of work around ASD, autistic spectrum disorder, this year, and we'll also be working on the ADHD pathway, developing a new service and a new process in which we will support that pathway to be delivered as fast and efficiently with the best outcomes possible for young people. And the goal there is to reduce the waiting list backlog and design that new pathway. So significant work around children, young people and families, and how we're going to be focusing on that work and continuing the great transformation plans that we've had over the past year. I'm now going to hand over to Dr. Vipul Parbat, who is our clinical lead for integrated urgent care, and we'll talk you through some of those achievements. Vipul.
Thank you, David. Hi, good afternoon, everyone. So I'm Dr. Vipul Parbat. I'm a GP in Dacorum. I'm also the integrated urgent care clinical lead and work closely with the urgent care team at Herts Valley. So as an urgent care team, we've been working very hard on many aspects of urgent care. And I thought today I'd highlight two specific areas which are very pertinent to Herts Valley. So in December, we saw the launch of NHS 111. The aim of NHS 111 first was to make it easier and safer for patients with urgent but not life-threatening health problems to use NHS 111 either via the phone or online as their first port of call, and to do so before making their decision to travel. So by doing so, patients can be assured that they'll be referred to the right clinician first time. It's vitally important that any patient with an urgent care need is managed and treated safely in the right place first time. And although this has been the aim for 111, advances in digital technology have allowed for 111 to now digitally refer and directly book patients into a variety of services. So services such as their GP practices, pharmacies, as well as our urgent treatment centres and emergency department at Watford. So with the current COVID pandemic, being able to reduce the number of patients physically sitting in an ED waiting room is paramount in helping keep patients safe from the spread of the virus. But it also helps to reduce waiting times and pressures within the hospital. So we've introduced a booked arrival time for which patients are given to attend UTCs and EDs. and this helps to better plan urgent care for patients. As a CCG, we've also been developing plans for the urgent care service provision at St Albans City Hospital, and this is once services are able to reopen from spring 2022. So the MIU, which is at the St Albans site, has been temporarily closed as part of the COVID-19 response, and remains so as part of infection control measures to protect planned surgery on the site. So over the summer, we invited local people and stakeholders to share their views on options for the site as part of a public engagement. And we received in excess of 3,000 responses, which we presented back to the CCG board just last week. The board agreed to take forward our preferred option of an integrated urgent care hub. Now, the integrated urgent care hub, so what this does is this will provide a minor illness and injury services for the patients, and is led by specialist nurses, and also has support from GPs. Appointments can be booked through GPs in 111 and the 111 service for the integrated urgent care hub, which means that we can manage demand and also minimize the number of people attending to help with infection control. What the hub does is it allows us to deliver improvements for patients, whilst keeping additional costs and demands on our GP workforce at a level that's realistic and deliverable. So we're now doing more work to spec out the new service, and we'll soon go out to the market for a provider to run the new service, with the aims of opening the doors in spring next year. So that was a very quick whistle-top tour of what we've been doing in urgent care, and I'll now hand over for you to hear about the development of cancer services.
Thank you, Vipul. Okay, I will provide an update currently on the position on cancer services. So as part of delivering the NHS long-term plan, we've continued to focus on early diagnosis of cancer and to provide timely access to treatment for patients once diagnosed. This should happen within 62 days of an urgent GP referral, and we've invested in giving GPs access to directly arranging diagnostic tests for patients for certain types of cancer, and have introduced a pilot scheme that allows patients to be investigated for an underlying cancer on the basis of symptoms that give their GP cause for concern, even if they don't meet the stated criteria for an urgent referral. We're also working with Herts Learning Disability team nurses to support women with learning disabilities to attend cervical screening appointments, addressing significantly the lower uptake in this population. While access to care and other critical services has been maintained throughout the first and second waves, the pandemic has affected the entire cancer continuum through screening, diagnosis and treatment, as well as follow-ups in palliative care. So cancer activity and treatment rates have remained overall fairly stable, with innovations in COVID-friendly treatment delivery and adapted pathways. But as with non-urgent elective care, the hospital trust work closely with the CCG and local independent sector providers to maximise their capacity into supporting patients through this pathway. Plans to make the much needed changes to the Mount Vernon Cancer Services are being developed and will continue over the next few months as part of the review by the local NHS and NHS England. If there was to be a consultation on proposals arising from the review, this will only happen once we know what funding will be available to support any developments, but you can find further information on dedicated review websites that we can share going forward. We then move on to updates regarding acute care. We've continued to work with West Herts Hospital Trust on the redevelopment of the hospital sites, having been included in the government's hospital investment programme. The Trust's hospital redevelopment team is continuing the good work alongside CCG colleagues to develop an outline business case for their proposals. The proposals are based on a 3-site option and are supported by clinical strategy, which outlines plans for developing services across all 3 sites with a clear role for each. Earlier this year, the CCG supported the Trust in running a Your Care, Your Views engagement exercise, which many of you from the public may have been involved in, to explain how services would be organised across the 3 sites. Watford is to be the main emergency and critical care site, with St Albans as a planned care and cancer centre, and Hemel Hempstead will be the centre for supporting patients with long-term conditions. Now, the engagement showed strong patient and medical support for the Trust's principal aim of streamlining clinical care so that fewer appointments are needed. The Trust also appointed architects BDP to draw up designs and obtain planning approval for each of the sites. During May and June, they carried out pre-planning consultation to invite comments on a design scheme for the main Watford site, just as a precursor to seeking planning permission. A similar process will follow for St Albans and also the Hemel sites. The outlined business case will need to present detailed costings for the preferred option, and the Trust is currently revisiting costs to make sure that its development scheme can be delivered within the agreed financial parameters, as well as delivering the government's overall expectations of offering a full digital integration, building to zero carbon standards and taking account of the lessons learned from the pandemic. So a significant amount of work is taking place in that space, and we feel that we're engaging with the public as strongly as we possibly can. The Trust is working towards submitting its outlined business case in spring next year, and we continue to see this as a priority for our patients and our population in West Hertfordshire. We are still committed to patient involvement, and our patients work in redeveloping services and other pathways. But to work up and ensure that it's linked, we have focused work in this area, and I'm about to hand over to Alison Gardner to give you an update on the patient engagement work that we've been doing.
Thank you, David. Before the pandemic, we held regular events to update patients on new developments in health and social care, to listen to their questions and invite feedback to help shape services. So that we could continue to connect with our patient networks, our patient practice groups, and other local people, we have run virtual engagement sessions on particular topics. We've held around 20 sessions since last September on a range of subjects, including dementia, bereavement, mental health, cardiac rehabilitation services, the prevention of type 2 diabetes, NHS 111 First, GP virtual consultations, and the findings of a survey by Healthwatch Hertfordshire on patients' experience during the pandemic. We've had 400 people join us across these various events, and we've also continued to use our reader panel to review patient information material, including a winter wellness guide for older people, proposals for urgent care services in St Albans, and patient letters about changes to medication. Our board's Patient and Public Involvement Committee stood throughout, albeit in shortened form. They supported me in providing continuous assurance to the board that engagement with the public continued and was, of course, regarded as more important than ever. Recently, the committee embraced change again, hosting a lively, interactive session for a wider group of patients, exploring the future of patient participation in South West Hertfordshire. I'd like to thank committee members for their long-term and ongoing commitment, flexibility, and active support of Herts Valley's participation and engagement work. Now, to bring us right up to date. Earlier this week was the first meeting of the patient participant initiated and led West Herts Diabetes Support Group. This group will have a programme of monthly webinars targeted at people who have diabetes, are pre-diabetic, or are keeping a watching brief on the matter due to family or other factors. The webinars will be geared toward helping the ability of patients to self-manage and improve their own well-being. Most definitely a step into the future of patient and public involvement in Hertfordshire. Thank you, David. Back to you.
Thank you, Alison. And just to quickly also say that we've been doing lots and lots of integrated work in around support in managing some of the challenges that we're facing with the County Council, the Mental Health Trust, Community Trust, voluntary sector and patient reps, to our collective efforts toward reducing health inequalities and preventing ill health, and providing better coordinated and tailored care for people who receive their care from a range of professionals. The programme of work that we've been working on is to improve support for adults, especially frail and elderly population and people in care homes. And all of our localities have been working hard to continue to work in a joined up and integrated way. So there are lots of work that's taken place over the last 12 months, but what we do need to recognise here is the work that we've done around COVID-19, and I'm going to talk about our role in that, and we're going to see some videos as well. But the biggest area of our work continues to keep residents healthy and safe from COVID-19, and to make sure that the delivery of our health services continue. When the pandemic hit, the whole of the NHS in the country had to adapt to the way of working in a new model, and the services are delivered. The workforce, and especially the CCGs and all of our frontline colleagues across the whole sector, has responded amazingly. And we want to do a big thank you and a big shout out to say we really appreciate everything that you've done, and everybody in the CCG especially has worked tirelessly on this front. And you've had to work in different ways and taken on new roles. So before we talk any more in detail, I just want to share a short film in which some of our colleagues will share their experiences of the last 12 months.
Hello, my name is Mary Stewart and I work within the Communications and Engagement team at Herts Valley CCG. At the beginning of the year, myself and my colleague Heather had the opportunity to support one of our local PCNs with its COVID-19 vaccine rollout. We volunteered at the Bridgewater Surgery in Watford. Our role was to register patients onto a national database and take them through a series of questions ahead of their jabs. The clinics were busy, but the surgery had a system in place that ran like clockwork. What stood out for me the most was just how grateful people were for what we were doing. I found it really rewarding to volunteer, and I felt totally supported the whole time I was there. I wouldn't hesitate to volunteer again in the future.
Hello, my name's Heather Aylward and I'm Public Engagement Manager, and I was briefly redeployed to support colleagues working at a vaccination centre in Watford. And what stayed with me was the patients that came in, many very elderly, were so grateful and so enthusiastic about having the vaccination, and it just reminded me what a wonderful institution the NHS actually is.
Hi, Tim Anfligoff here, Head of Community Resilience. What's got me through the last 18 months has been the amazing contribution of the voluntary and community sector here in Hertfordshire. 10,000 volunteers have come on stream. Small groups have made huge efforts locally to adapt the way they help people, and we've been able to support that with small grants from our own money in the autumn and Captain Tom monies in the winter. And we'll be doing that again this winter. And our talent and innovation in this sector has been recognised. One of our link workers spoke at the International Social Prescribing Conference on his work with the homeless. Carers in Herts were there too, speaking about the way we can improve the health and well-being of carers. And a link worker who's a veteran from Herts 5 PCN also produced a podcast with the RCGP and the Personalised Care Institute on better help for veterans. So an amazing testimony to a huge amount of effort.
My name is Joe Warren. I'm the Senior Information Analyst at Herts Valley CCG. During the year, I've moved across from Milton Keynes University Hospital to the CCG, and I'm learning all about the different systems and processes and everything else the CCG has on offer. In terms of welfare, I've been doing lots of park runs, other runs and cycling.
My name is David. I'm a pharmacist who works in the Pharmacy and Medicines Optimisation team within the CCG. Usually I work in the office working on prescribing in care homes and antibiotic prescribing. I'd just like to pay tribute to my line manager and senior management within the organisation for supporting my redeployment. It involved a total change of role. I was involved in the vaccination of priority groups in the Luton and Dunstable area. I'd also like to thank senior staff for supporting the wellbeing of both myself and also the staff that I manage.
Hi, I'm Kelly Taylor. I am currently working in the ICC as the project lead for PPE. Very different to my role as office manager, which some of you will know me from. I started in November 2020, hit the ground running, as they say, very much out of my comfort zone. Had to adapt quickly to the ever-changing guidance, and just grateful, really grateful for the opportunity to have been part of this and to have learned so much.
Hi everyone, my name's Dipesh and I joined the vaccination programme during the pandemic. I have to say I'm truly grateful to be a part of the vaccination programme and to meet some really wonderful people across the whole of the ICS. In my personal time, I like to spend time with my family, my 2 young children, you'll be able to see here, blowing bubbles. And it's after a crazy day at work, it's nice to spend some time with these 2 crazy children. And I also like to spend some time gardening. I've taken that up recently as well. However, I still can't tell the difference between a weed and a flower. On a serious note, I'd like to say a big thank you to each and every one of you. You've been truly amazing. I'm so proud of what we've achieved in so little time for the vaccination programme. And for all of you, thank you for being amazing NHS ambassadors. I know a lot of you spend time with friends and family outside of work, demystifying some of the myths about the COVID vaccine. So cheers, thank you for that.
It's a fantastic video of all of the efforts that our staff have put in over the last year in terms of the pandemic, and it's been fantastic to hear from them all around the challenges of moving into other roles, taking on new and thriving challenges, and being able to respond really positively to the challenges represented to us in the pandemic. So the next area I'd like to cover is kind of managing the system pressures. So we know that during this period of time, especially over the winter period and through the height of the 2nd and 3rd wave of infections, we've worked alongside system partners to manage the urgent and emergency care needs on a day-to-day pressure of increasing hospital admissions, as well as pressures on other services of ambulances and the need to convey people safely to hospital. Hospitals once again face severe pressure in terms of their bed occupancy and the ability to carry out routine surgery, and an increased staff rate of sickness due to isolation and COVID. ITU services, intensive treatment unit services, were maintained, and while this posed significant pressure across all acutes, and having to redesign surge areas and replan and purpose new parts of the hospital to succeed, they did a fantastic job in ensuring that we always had capacity for every patient who needed care. Keeping people out of the hospital and caring for COVID-19 patients in the community was a priority for us, as well as a CCG, and both to minimise the pressures on our hospital, but also in terms of the benefits to patients. And I want to introduce you now to Daniel Conway, our board GP, who led on work in this space for us. So I'm going to now hand over to Daniel.
Thank you very much, David. So, I mean, we recognise COVID-19 as being and continues to be an extremely difficult time for our population, our patients, and the health service. The health service has responded by accelerating new ways of working, which can be demonstrated in our approach in caring for people with COVID-19 during the course of the pandemic. Very early on, it was really clear that we needed to closely monitor people's oxygen levels when they had COVID, particularly people at higher risk of more severe illness. And at the same time, hospitals were becoming quickly overwhelmed with patients suffering from COVID, and we needed to find a way to help look after more patients at home. So as a response, we quickly developed new ways of helping patients, jointly collaborating across multiple health service organisations and also the voluntary sector in order to meet these challenges. So West Herts Hospital set up a pioneering virtual hospital, which enabled their clinicians to be able to look after patients with COVID remotely by using very simple oxygen monitor devices that fit on your finger, so that oxygen levels could be easily monitored at home, and enabling patients to be quickly recalled to hospital should any deterioration occur. And to date, over 3,000 patients have been looked after by the virtual hospital. We also rapidly developed COVID-19 clinical pathways, which set out how primary care clinicians could identify patients at higher risk of more severe illness, and also clearly laid out when patients would need to be referred urgently to hospital for assessment. For example, if their oxygen levels fell below a certain threshold, they would be referred urgently. And then following that hospital assessment, if patients did need to be admitted, they could be referred into the COVID virtual hospital for further care at home. And this was also supported by an oxygen monitor delivery service in conjunction with the voluntary sector, which meant that oxygen monitors could be delivered to patients' houses within a few hours of a clinician requesting them. And this service has empowered patients to self-monitor their condition when they have COVID, knowing exactly when they should contact someone for help should their condition deteriorate. And over 1,300 monitors have been handed out so far. And we hope this simple intervention has helped to save lives during the pandemic. And in addition, very early on, we set up 4 COVID-19 primary care assessment hubs in physical locations, which were carefully designed to enable clinicians to safely see patients with COVID symptoms face-to-face, thereby supporting general practice to remain open for patients throughout the pandemic by minimising the spread of COVID within practices. Because if COVID spread within practices, whole teams could go down, really disrupting care further. The success of these pathways and the virtual hospital have now paved the way to expand the virtual hospital approach to a wider range of clinical conditions. And this means we will now be able to safely look after more people at home, preventing more hospital admissions, and we will also have the ability to be able to discharge more people earlier from hospital. So despite this devastating pandemic, the health service has responded to quickly innovate, which we hope will be of benefit to the population of South and West Hertfordshire in the longer term. So I'm going to hand over now to Dr. Richard Pyle, who's our board GP.
Thank you, Dan. One of the things that I wanted to talk about today was really to focus down on what primary care has been doing during the pandemic. David has already spoken about the great work that's been done across the system and how proud we are of all the different sections of that. And I really wanted to spend this time just to focus that little bit on primary care. It's often said that change really requires challenge or pain to occur, and we've certainly had a lot of challenge and a lot of pain over the last 12 to 18 months. And I'm certainly working harder than I ever have done in my 21 years as a GP. And general practice I'm very proud of the response that we've had from general practice and the different ways of working that we've embraced as a result. And in fact, many of these ways of working we knew were needed long before COVID hit. But there was always a reason why we didn't do them. It was too much effort, too much cost, too much fear over rocking the boat. And but when the pandemic came along, it meant that suddenly change occurred at a huge scale. So some examples of the ways that we've been working differently include using e-consultations, doing more reviews for medications and long-term conditions virtually. We've been offering video consultations and phone consultations, as well as face-to-face consultations for our patients. And we have continued to offer those all the way throughout from when we very first went into lockdown. And it's been great to receive very positive feedback from patients. I am, of course, aware of the challenges, and I'm not suggesting that the whole system is working perfectly. We are still under significant stress. But the flexibility that this offers, that's so much more convenient for patients, the way that they can have a virtual consultation in a way that works really well for them, the way that we're able to respond quickly to their needs, and the use of e-consultations so they can send us the information that they need us to be aware of, has been really well received. And interestingly, we've had patient surveys done during the pandemic, and they've been very positive about the response from primary care. We've all had to get used to new ways of working, and obviously those will continue for some time. I think some of the things that we've learned we're going to continue doing, particularly our use of technology to improve the service that we offer patients. We'll do differently when restrictions permit and life becomes a bit safer and a bit more predictable. But at the moment, really, in primary care, we're focusing on doing both as good a job as we can for our patients and also trying to look after the well-being of our workforce as well, because ultimately we need our doctors and our nurses, our receptionists, our physios, our pharmacists, all members of the team to be in a fit state to continue to serve the patient population of each practice. And so that's a balance that we have to bear in mind as we continue to work our way through the next few months. Thank you very much.
Thank you, Richard. And thank you, Daniel. So now we're going to talk a little bit about our COVID-19 response in the community and how we've supported people either on the shielded patient list. And you'll have heard from me earlier talking about the community link workers and care navigators that have played a vital role in this area. And they've been helping shielded patients on the list with food drops, appointments that they've needed to maintain, virtualisation to ensure they're digitally enabled when they were isolating, and provided an amazing amount of support in that area. We've also supported patients with long COVID, and in November 2020, Herts Community Trust, NHS Trust, began their COVID rehabilitation clinics, which were launched to provide physical and psychological support for those patients experiencing ongoing symptoms and complications after having the virus. The service is delivered by a multidisciplinary team, which includes a community GP, pharmacists, physiotherapists, pulmonary rehabilitation, respiratory nurses, speech and language therapists, dietitians and occupational health therapists and clinical psychologists. So you have a huge multidisciplinary team there, and I'm sure I've missed people out, but it just demonstrates the breadth and the reach that COVID has had on individuals and the need to support them ongoing. Support for care homes. Care homes we know have been significantly affected by COVID, and our care home improvement team has worked closely with the community health providers and primary care to provide essential support to the care homes, including training, testing and outbreak control. We've delivered infection prevention control training to all care homes, supported living and assisted living, and domiciliary care providers on a rolling basis, just to make sure that everybody is safe when they've been engaging with staff. Each adult care home has a dedicated care home improvement team nurse, and we have continued to provide that support to maintain contacts between primary care and community services, and each care home has been given an iPad to continue that virtual support needed. We now go on to recovery of services. So we know that there's been significant challenge in maintaining planned care across the system. And we know that routine hospital care was paused during the pandemic. Waiting lists for some treatments have grown significantly. However, throughout the pandemic, the local hospital trust has continued to prioritise and diagnose and treat patients with cancer. Now, hospital teams are assessing all patients to prioritise diagnosis and treatments, and I know that there will be questions about how we're managing that. Hospital teams therefore are assessing all patients on their waiting lists to ensure that those with clinical needs that are the most urgent are prioritised for treatment. These clinicians include GPs, we have use of national guidance from the Royal Colleges and their professional judgment in making those decisions alongside consultants. And we're monitoring progress in tackling those waiting lists to ensure higher risk patients are prioritised, and initiatives are being deployed to bring waiting lists down as quickly as possible. We're also working closely with our community providers who are continuing to provide assessment and diagnostic and treatment services, including outpatient procedures and surgery to patients who can have this in a community facility rather than in a hospital. So the waiting lists will be displaced across lots of different providers to make sure that people get the best care they're needed. Patients have also given information on how to support their wellbeing and mental health, and we've also worked with West Hertfordshire Hospital Trust to refer vulnerable people who are waiting for elective surgery to the community navigator team so that they're maintained and supported during their waiting time to support their health and well-being, some of their emotional resilience over that period. We continue to work with the County Council and government departments and others to help public access to PCR COVID-19 tests and rapid lateral flow tests when these became available in February 21, and we've provided regular updates on those testing sites. Now, we do know that there's been significant other set of services being delivered around the vaccination programme, and this has been really, really key and a significant piece of work that primary care has really stepped up into. The NHS COVID-19 programme, the largest ever vaccination programme in the history of the NHS, started in December 2020 and has been one of the success stories of the past 12 months. Plans were developed very quickly and have been responsive to changes brought about relating to vaccine supply issues, adjustment to the priority groups for vaccination, and changes in the guidance for second doses. The collective effort and goodwill shown by GPs, their practice staff and colleagues in the community and hospital trusts, as well as the enthusiasm of the general public, should not be underestimated. The team within the ICS and the teams that have all worked on that vaccination programme within the CCG have done a fantastic work, and we just need to acknowledge that in terms of coordinating and managing such a large-scale project. GP practices working together within primary care networks established 10 GP-led vaccination centres and delivered a significant amount of vaccination over the period that we've just been through. All care homes were visited and residents and staff have been offered the vaccine. By mid-February 2021, 91.5% of over 70s have received their first vaccination, and all housebound patients in priority groups were offered a vaccination. Transport assistance was also in place to make sure that people could achieve their appointments. Health, social care and council services have worked together to make sure that all groups were able to access the vaccine, particularly those from vulnerable and hard to reach groups, such as people who are homeless, rough sleepers, suffer with substance misuse and travelling community, alongside people with learning disabilities. We've offered tailored outreach clinics, and the programme has really reached deeply into communities to ensure that we do the best that we can on behalf of our population. So before I finish, I want to say a thank you to all the NHS staff, wherever they're working in our system. NHS staff are a resilient bunch, but the pandemic has taken a tremendous toll on everyone. But you've done a fantastic job, everybody within the CCG and everybody within the wider system and health and social care and the voluntary and community sector. As an employer, it's vital that we do all we can to support our staff's well-being, and we have a Here For You programme, and we've tried to do as much as we can to keep people's emotional health and well-being at the forefront of our plans as a CCG, and we give 24/7 confidential help and support to anyone working in that sector, and would encourage anybody to take that up who works within the NHS. And I also really want to stress to everyone that these NHS services remain open and we continue to treat people as quickly as possible. We're prioritising those with most urgent and clinical needs, and additional outpatient appointments and clinics and surgical sessions are being run in the evenings and weekends across the NHS and independent sector. It really has been all hands to the deck and delivered massively in terms of the support that we've needed to provide to our population during this pandemic. But it's just an opportunity to remind everybody here that if any patients feel their symptoms and you're watching and they've changed, or you have any new concerns, it's really important that you contact their GP or department that you're receiving treatment from, so our clinicians can ensure that you are fully supported. So looking ahead into the next steps of where we're moving to, we do know that our healthcare partnerships and our integrated care system, as Beverly talked about at the start of this session, are really the journey that we are moving towards. We know that from the 1st of April 2022, the Herts Valley CCG will cease to exist as a separate entity, and our legal responsibilities and duties and powers and our workforce will transfer into the integrated care system. For the next 6 months, we will continue to be responsible for delivering local services and to serve our local patients. Within the Herts and West Essex ICS, there will be organisations that make sure that the needs of the local people are being met, and we are working hard on our South and West Herts Healthcare Partnership, which will be an alliance of existing organisations involved in supporting and commissioning and developing health and social care across West Hertfordshire. So I'll now move on to Nicholas Small, who will close the session, but a big thank you from me for all of the work of all of the CCG staff and everybody out in the wider health and care system. Nicholas.
So thank you, David, and I think, you know, hopefully we've really given a wide account of the different ways in which we've been working with the total system. But I just want to go on to the questions now. I think many of them have actually been answered in the chat. I think the one on the diabetes clinic, it's possible we may have to come back to give some more specific answers. But perhaps I can just check with my colleagues. Is there any question that we won't have then answered?
Yeah, I think, hello Nicholas, it's Juliet here. I think there's a question about secondary care and waiting list. And I know, David, you covered a bit in your piece, but I just wondered if there was some more information we can provide about that. They're asking for, so Alan B is asking what metrics we've got about the backlog and the steps taken to reduce it. Thank you.
Hi, Alan. Thank you, Juliet. I'm not likely to be able to provide some metrics on this call without getting into significant detail about different elements of care, whether that be through cancer to dermatology to orthopedics, etc. But what we are doing, as I said in my piece, is we are significantly working on that as a collective within our health and social care partnership. We have plans in place that are managing the risk, though we know that the numbers are significant. We are working them down. Cancer is in a very good position at the moment, and we know that we're able to see individuals with serious and fast-paced need for a diagnosis and treatment. What we can do is provide some more data to that question so that we can give you a sense of what those numbers look like. And they're also available on our public board papers that were only recently just published to give you a sense of that. But we'll provide more information, Alan.
Okay, and can I just also, I think Councillor Wren has also just asked about the procurement process, finding out more. Well, that will be according to NHS guidance, but it will be the relevant team in the CCG that will guide us in that. So we can provide more written information if you require it. As I don't see any further questions, I think I really would like to thank everybody today, all of our speakers, all of our participants, and actually we've had a really large number of people who've dialed into this, well over 100, I think. So it's really excellent that you've done that. We do hope to be able to celebrate some more of the achievements of Herts Valleys with a session in the spring before we formally cease to exist, and a little bit more about that will be released nearer the time. But for now, I just want to say thank you to everybody, and I really hope you're going to stay on now for our health inequalities workshop run by Ian Cansola. So I don't know if Ian Cansola wants to come into vision now at this point. Fantastic. And we will hope to have a really good session on that. So thanks once again, everybody, and please do stay for this. It's such an important part of our work. So over to Ian Cansola. Thank you.
Thank you very much, Nicholas. Hi, everybody. Good afternoon. Hopefully you can hear me and see my screen. So welcome to this workshop on health inequalities. My name is Oyinkansola Ojoramukadu, and I am one of the lay board members of the Herts Valley CCG, or one of the non-executive directors of the board. And another role that I have is as a PhD candidate at the London School of Hygiene and Tropical Medicine, where I am studying for my PhD, looking specifically at childhood immunization uptake within Nigerian communities. And obviously that project sits within a wider context of health inequalities, which didn't start this year or even last year. They've been with us since the beginning of time, but obviously we've heard so much more about them because of the impact of the COVID-19 pandemic. And if you'll recall, at the beginning of the pandemic, there were studies and reports showing that people of ethnic minorities were more likely to catch COVID-19, to have severe reaction to it, and then to unfortunately go on to die of COVID-19. And that just really goes to show the impact of COVID-19 on entrenching health inequalities in our community. And unfortunately, we're not immune to health inequalities in our locality. And so the objectives of this session really are twofold. One is to consider the impact of health inequalities in our locality, and to think about how we can address those and work together to address those. And secondly, to go through some findings of a literature review that I conducted as part of my research. And then at the end, there will be an opportunity to have a more interactive discussion and to think about how we can make Hertfordshire healthier and more equal for all. So this, hang on. Okay, this slide shows the ethnicity uptake of the COVID-19 vaccine across the ICS as of 4th of September. And so you can see the different ethnic groups across the screen here. And the green shows people who have received 2 doses, the yellow is 1 dose, and the red is those who are remaining. And you can see the group with the highest uptake is the British group here, with just over 80% of people being double vaccinated. And the group with the lowest uptake is the mixed white and black Caribbean group, with just under 50% being double vaccinated. And there are complex and nuanced stories within each of these ethnic groups as to people's attitudes, perceptions, and behaviors to the COVID-19 vaccine and their vaccines more broadly. But the story here is that you can see the ethnic disparities here. But there's been some really, really fantastic work being done within the CCG and then the ICS more broadly, thinking about how we can improve access to vaccinations and how we can literally take vaccines to people where they are. So there's been a series of pop-up clinics in mosques and churches and community groups, and there's been webinars making sure people's sensitive questions about the vaccines have been answered and making sure that people have accurate information with which to make health decisions. And that has not only the short-term impact of the accepted and received vaccine, but then also the longer-term impact of making people feel much more able to voluntarily interact with primary care, and that will impact on people's likelihood of interacting with primary care later on down the line when they're making health decisions later on. And so the CCG has really championed this project, essentially by changing one mind at a time. And this picture of where we are at the moment is a much better picture of where we were at the beginning of the pandemic, but obviously there's a lot more work we can do. And hopefully this session can be one of the ways in which we discuss how we can address health inequalities through the COVID-19 vaccine and then more broadly as well. So taking a step back to pre-pandemic times, if there ever was such a time, I conducted a literature review looking at the Black experiences of primary care in the UK. And this was for 2 main objectives. Firstly, to isolate the Black patient experiences within a larger grouping of ethnic minorities or BAME or BME. I wanted to isolate and tease out that Black patient experience. And then secondly, to codify this in for what I believe to be the first time in a qualitative systematic review, and to put that all together and make that available for people and those who write health policy. And so the review had 6 major themes, which I'll run through now, and then that will also help in the discussion later on, where we're discussing and thinking about health inequalities in our patch. So as I said, there were 6 major themes in the review. The first is expectations of healthcare and health-seeking journeys. Second is mistrust and trust. Then we have barriers to information in the form of language and finances, followed by impact of primary care service. Then we have the cultural disconnect, and then lastly, being perceived as different because of ethnicities, so stereotyping. So if we zoom into the first one first, so expectations of healthcare and health-seeking journeys. So there were 41 papers that came through in the review, and so the rest of this presentation will be about those papers. But in this theme, there was an idea of people's expectations of the NHS and the healthcare they received in the UK being impacted by the healthcare that they had received where they were more familiar with or where they were migrating from. And so this quote comes from a Somali participant who is describing her experience of accessing primary care in the UK. And she says, back home, we only have hospitals, whereas here you have primary care specialists and whatever. And so if we think about the NHS, it's designed in such a way that what can be done in the community or in primary care is done in primary care. And we're trying to keep our hospitals, as we saw with the COVID-19 pandemic, as free and as available as possible for people who need it. But this lady's experiences back home were directly impacting, she was literally mapping her behaviours from home to the UK, which was affecting her experience. And this is also true and trickles down into treatments, where the second quote here comes from somebody from Zimbabwe, who she's describing how she received antibiotics for a particular ailment, but is not receiving antibiotics in the UK, and thus is affecting her experience of the UK healthcare system. And then moving on to health journeys. So if you consider yourself on a health journey from the moment that you're sick and then you're trying to get better, not everybody or not all cultures have the same understandings of medicine, of health, or of the body that would allow people to make the same journey. So you have people who might go directly to the GP or to the hospital. Some people might use religious tactics. Some people might use herbal medicine or acupuncture and things like that. So not everybody has the same understandings or the same health journey to get cured or to feel better. So moving on to trust and mistrust. Interestingly, where there was trust, they didn't necessarily imply a common ethnicity. So Giantoli and Catan talk about, there's a case in their paper where there was a Black patient who says that she trusted her white nurse because the two of them had actually gone to school together. And so that shared experience allowed that trust to be fostered. But where there was a preference for somebody of the same ethnicity, this particularly came out through the mental health papers, where Black patients described that Black psychotherapists would be more likely to understand and empathize with their lived experiences. There's also this idea of people being very aware of their outcomes because of their race or ethnicity. And this third quote comes from an author called Islam, and he says, some of the African Caribbean community take a very rational view that mental health services are punitive. They're sectioning a lot of them. And the final quote here comes from a Black woman reflecting on her GP, who she describes as a strange white man. You're always remembering your history about all the horrible things that were done to Black females in those days. And so this idea of not being able to shed the medical racism and historic racism that's happened to this community and being very aware of it, even in the appointment, and thus impacting your likelihood of voluntarily interacting with primary care and your experience once you get there, or if you get there. Next, are barriers in the form of language and finances. So language is pretty self-explanatory. This came up particularly with papers focusing on the Somali community, where people didn't speak English or spoke Italian or Arabic. And with the interpreters, so you had interpreters who are formal interpreters who are hired by the NHS, and then informal interpreters who are friends or family members of the patient who come along to the appointments. And after a lot of these cases, in speaking to the researchers, the patients often described that they didn't feel as open as they would have liked to have felt to disclose all of their symptoms to the clinician because of the informal interpreter, because they were fearing gossip within the community afterwards. And then moving on to the financial barriers, this came through in the perceived need to pay for primary care services, even if it wasn't the case, but then also in the need to take time off work, and then also to seek childcare for people who had young children in order to attend primary care appointments. And then the primary care service that was cited as being too expensive to access was dentistry. So this final quote comes from a participant who says, "I can't afford to go to the dentist, it's too expensive." And then we have the impact of the primary care service itself. So when the papers were coming through in the review, there were different groups of papers and different focuses. So there was maternity care, mental health services, GP appointments, immunizations, but then also cancer care. And then with the cancer care and the maternity care papers, there was a kind of an expected kind of care, a slow, sympathetic, considerate care where the patient's needs were being prioritized. But this wasn't necessarily felt to be the case. So this participant says they're not she's describing the team, and she says they're not sympathetic because it's a job that the nurses do all the time, every day of the week. It felt like it was a conveyor belt. And this trickles down and causes a kind of vicious cycle where, because of poor experiences, people then become less likely to interact with primary care and have poor experiences along the line. And so the second quote says, that is probably why a lot of Black women don't bother going to the system. The majority have had nightmares. And so something that we can think about together at the end of the session is how we can actually cut that vicious cycle and make sure that people have positive experiences and make sure that the patient experience is one that is iteratively considered. And then I'll bring your attention to the final quote here about mental health services. So these authors actually cite GP practices themselves, or sometimes as being the barrier to mental health services. And so they describe a case of a woman who is trying to access primary mental health services, but her GP tells her that you're not depressed, you're doing too much, you're not depressed, and didn't support her in accessing those services, which she eventually did access. And then cultural disconnect. So we're living in a society where so many cultures are coming together and we're all trying to live and work harmoniously as one. And it's sometimes there are disconnects, and not everybody has the same understandings of health or of the body or of medicine in this context. And so the third quote here is from a Black man describing, I don't think it doesn't say where he's from, but he's describing medicine in Europe. And he says, in European countries, they don't know about jinn and evil eye. They don't know that they need to recite the Quran. And so if you imagine this man trying to describe his symptoms with his NHS trained GP, and the two of them are trying to communicate, they really are going to struggle to communicate because of their completely different understandings of health in the body and things like that. And so maybe cultural sensitivity training or things like that, or having somebody who is familiar with that culture can definitely help in those kinds of situations. And then finally, on this page, the mental health stigma that sometimes persists in Black communities. So this woman is talking about her child who has received a mental health diagnosis and is receiving treatment. And she describes that we would actually prefer our child to have a physical problem than a mental health problem because it's like a mark on you for life. And then the final theme, being perceived as different, so stereotyping. This particularly came through in the mental health papers. And so one patient describes here that if there's a mental health patient who's a big Black man, 6'2", somehow they're more afraid of him than a 6', 7 foot white man. And this again trickles down into treatments, where another patient describes that they really don't believe that Black people can be treated, that Black people can be given therapy, that you can talk to Black people. And thus this patient says that less invasive treatments aren't necessarily frontline in their experience for Black patients. And okay, so before we get to the discussion questions, those were the major findings that I had from my review. As I said, this was specifically looking at the Black experience, but obviously a lot of these things can be applied to people of different ethnic minority groups. And that's definitely something that we can talk about in this part now. So if anybody would like to contribute, we should have enabled the capacity for you to unmute yourself. But if you raise your hand first, and then we can pick on you just to make sure there's an order. But there are some discussion questions up on the screen. If anybody has any ideas or experiences that they want to share, please feel free. Thank you. You can also drop them in the chat and then we can pick them up from there.
Okay, I think we've actually unmuted people, so I don't know if people want to sort of start speaking. Ian Consolo, I think one of the things that, just to sort of set the scene as well, is that it's been really quite shocking for us as GPs and GP practices to see the discrepancy in the vaccination uptake rates, and that was becoming apparent very soon after the vaccination program started. So I think that I think it's really made us as a system, as a clinical commissioning group, but wider than that, really start to challenge our views about how well we're addressing the health needs of pockets of our population. And I think you've brought that out very eloquently. Who would, I'm going to sort of, I don't know, Tim, I'm going to start with Tim because Tim's got a short question. I'll come back to John's in a moment. But Tim, do you just want to just raise your point if you're able to verbally?
Hi, Nicholas. Yeah, no, it was a great presentation, Ian. So I was just hoping that we could have the slide shared.
Yes, no problem. I can definitely share them with you afterwards.
And I think everything you said reinforces, as has already been mentioned, the social side of all of this medicine. That it's not just about the stuff in bottles and the pills. It's the way people are treated and the cultural expectations and experiences that determine how useful medicine can be to them. I think it's fascinating.
Absolutely. Thank you. That's right. There's a social side to it all, and it's not just about, I mean, the social side will impact on whether you voluntarily access primary care or not, depending on how you're treated and what your experiences are like. So
lovely. Yeah, just to remind everybody that it's on the chat. If you put your hand up, then we'll know that you want to speak. Councillor Wren, over to you.
Yes, thank you very much for a very interesting presentation. Can you expand a little, please, on the role of particularly the Islam, in as much as the will of Allah, etc., is rather difficult sometimes to the will, if you like, of NHS, and different things happen. Could you expand a little on how, from your own findings, you might give us any indication as to how to actually cope with this? Thank you.
Yes, that's really interesting. So I think, well, with religions more generally or more broadly, religion often has an impact on people's health cosmologies, where people have different understandings of how the health landscape works and what's going on there and what's preordained and what's destiny and what's what can we actually change and what's already your fate. And I think that can often impact on people's proactivity is not the right word, but their likelihood to interact with biomedical care, which is what we practice in the NHS. And so sometimes there can be a conflict between those two ideas as to what the deity wants, or what is my destiny versus what can I change. And this is something that kind of can cause delayed presentation because people have tried different tactics to help with their symptoms. So I don't know if that helps answers your question, but it's definitely a very interesting nexus of two very different worlds and different approaches.
Thank you.
Anybody else wants to ask a question, to put their hand up?
I think there's one in the chat that I can see here from Brian Gunson, who says, okay, you looked at different generations and where their attitudes differ. And this is something that didn't necessarily come through in the review that I did, but this is definitely true. Different generations have different experiences, and there are lots of different papers available that look at this specifically. And even with the COVID-19 pandemic, early research showed that people who had just migrated from whichever country in the African continent were more likely to take up the vaccine because they had seen for themselves the impact of not having a vaccine. So they've seen the impact of polio with their eyes, or seen the impact of other diseases that we don't necessarily see in the UK as often. And so they were more likely to pick it up. But second, third generation migrants were more skeptical in that regard. But it's very interesting work going on looking at migrant generations.
Thank you, Brian, for that question. Can I just sort of tease a little bit out while we have a bit of time, me and Consola? It's just that I suppose, what can we do as a health and care system practically, and also working with our populations to sort of address some of the issues that you've come about? I mean, I think we've learned so much from this vaccination program, haven't we? But it's only of use if we actually use the lessons learned and do things differently in the future. I just wondered if you had any thoughts on that.
Absolutely. I think this is definitely an opportunity to learn from and to take advantage of what we've learned through the pandemic. And I think the traveller community had a really, really high uptake with the COVID vaccine. And I think one of the reasons for that was having that one-to-one interaction with the community and going to them and understanding what their concerns were and speaking with the people that were respected in that community and having that trickle down and cascade into the wider group. So I think using the people that we have that have those grassroots connections with these groups and getting them on board would be definitely the first step. And then being receptive to feedback and talking with the community, just as we're doing right now, would definitely be a major step in the right direction, I think, as well.
Thank you. I mean, it goes without saying that, you know, we have all of our practices, one way or another, have a patient engagement group, patient involvement group, but we know that very few people from ethnic minorities belong to them, so they're not truly reflecting our population. Okay. So I think in any way that we can help to improve that, and perhaps some of the people that we've been working with on, the targeted vaccine groups, we will be able to use those experiences to enrich our patient involvement, population involvement across the new health and care partnership in the future. Anybody else got a question they'd like to ask?
Nicholas, I'm just conscious that John Wigley, so it's Juliet here again. John Wigley put a question in the chat. I don't know if anybody's had a chance to have a look at that.
It's a very long question. He unfortunately doesn't seem to have access to be able to speak, which is I
wonder if that might be one that we look at. It is a long question, and looks like there's some numbers in it. So unless somebody can quickly give some thoughts to that, how about, I hope John can hear, even if he can't actually be heard, that we can give some thought to that and then get back to John. How does that sound?
I think that's, yeah.
And come back to him, yeah.
Okay.
Thank you.
Thanks, Juliet, for raising that. John says he can hear. Okay, good. Okay. I think Brian has also just written some links that will be useful. So I think what we're hearing in Consola, and certainly it's been the buzz in all of our primary care networks and the vaccination programme, has been a much better or beginning to better understand the needs of our populations and the pockets of populations that traditionally haven't always accessed care. And I think you mentioned, didn't you, about those one-to-one conversations are really, really important with somebody, be it a faith leader or somebody from their own group, that that has the trust of the community.
Right.
And I think that I think that's been really good work. I'm going to mention one group that I think were fantastic. I know there are many others, but there's a group called Afro GP Beds and Hearts, or Afro GP Hearts, which is a group of Afro-Caribbean GPs, and they were fantastic in actually, as Ian Kinsella said, of running some sessions and even doing one-to-one sessions with people who had specific questions and anxieties. I think that was a fantastic piece of work, and I think we should really congratulate them.
Absolutely. There's, like you said, there's so many groups that's been working on this, and we should definitely capitalize on that going forward.
Okay. I think we're sort of drawing to a close, don't you, Ian Consola? I can't tell you. For those of you who don't really know Ian Consola, she's joined us over the year as an associate lay member, non-executive member, and has really enlightened us across our health and care system about the work that she's doing and the research. And it's had a major impact, hasn't it, on the way that we talk within our health and care system. And we really want to build on that in the new health and care partnership for South and West Hertfordshire, as well as for the integrated care system. So thank you for presenting it so succinctly and sharing some of your research with us. So finally, I think that is my cue also to just say to people, it's never too late to have a vaccination. One of the things that we know is that although we've got sort of 90% in general terms of our population vaccinated, that still means there's 10% out there that haven't been vaccinated, even more in some of the groupings that Ian Consola said. So please tell your family and friends there's always a way of accessing a COVID vaccination, and we really hope that we can promote that across our population. Daniel, did you want to come in? Are you just or you appeared on camera? He's disappeared again. Okay, so thank you once again, everybody, to the whole, both of the AGM and for this session. And as I said, we'll have a celebratory update sometime in the new year. Thanks once again to everybody, all the people behind the scenes who organised everything, and we say goodbye. Thank you very much.